Hey guys, so welcome back. So today we will be talking about a crucial topic. Oftentimes it goes like unnoticed. Oftentimes because patients don't really like if their doctor says there is no. I can't really figure out what is wrong with you. I can't really tell what is going on with you. You'll be fine in a few days. It's just normal. Patient won't like if you say like this. But actually, there is really there is no condition that I can actually explain the illness or disease that the patient is suffering, and there is a proper way to tell them that this is just a temporary kind of illness or disease that cannot be explained medically, but you will be fine eventually. I mean, statistically, that's what it says. And this condition is known as a medically unexplained symptoms. Okay, so medically unexplained symptoms are quite often. For example, you can be having like muscle ache, uh, probably a trapezius muscle ache or something. For you wouldn't be doing anything like a workload or anything, but then you will be having like this type of pain, or probably you will have some kind of cramps or stomach aches or anything like out of a sudden. You can't really and when you go to the doctors, after doing a full diagnosis, full history checking and all those things, the doctor couldn't actually really find out what's wrong. And with Okay, this medically unexplained symptoms is also known as a diagnosis of exclusion. Means you exclude other possibilities of any other illness or disease, then only you actually will diagnose the patient as having something like is having this medically unexplained symptoms. So you would be wondering what is meant by this medically unexplained symptoms, and what are the types of symptoms that is under this MUS. So I'll be talking about that in this whole lecture video. So first of all, let's get into the definition first. Okay, what is MUS? MUS, or medically unexplained symptoms, are defined as physical symptoms persisting for more than several weeks and for which adequate medical examination has not revealed a condition that adequately explains the symptoms. Means, like, as I mentioned before, it is a diagnosis of exclusion. You try to like assume, okay, this could be the disease, but then uh, the what is that called? Okay, we will usually do this hypothetical deductive model whenever you are trying to do some clinical reasonings and all those stuffs. Okay, when you want to say that this patient would be having this disease, you would actually go through this certain premises, and when those premises are not found, that hypothesis is actually excluded. So when all the diagnosis of possible when all the possible diagnoses are actually excluded, then only you will come to the decision that okay, this is medically unexplained symptoms. Okay, so what is the impact of this MUS, I mean as in to the population as well as the nation? Okay, as for the population, okay, when you don't really know, when the GP don't really know what is actually going on, they tend to do an or like a over investigation towards the patient. So this over investigation, one of the uh, bad effect of this in over investigation, it can cause iatrogenic harm. Means harm from the procedures that you do onto the patients. Okay, this is very common. And as for the patient itself, okay, the sickness, absence, and decreased quality of life for people with MUS. I mean, I'll talk about UK economy first because MUS is more common there. So the sickness, absence, and decreased quality of life for people with MUS has been estimated as costing over like 14 billion per annum to the UK economy. And as for the annual cost for the NHS National Health Service for medically unexplained symptoms in adults of working age in England was estimated to be 2.9 billion in the year of 2008 and 2009. This is a very bad impact that medically unexplained symptoms has created onto the population of UK and also in some other countries. But more we'll just study about UK first. Okay. uh, Examples of symptoms. So when I talk about these examples of symptoms, okay, as for the okay, the number of symptoms, duration, and severity at presentation are associated with worse outcomes, like as if like longer the duration of the illness, the less positive outcome is with the treatment. And thus a good doctor-patient relationship as defined by the patient itself is associated with a more positive outcome, because a good doctor-patient relationship means they will actually like tend to reveal more, and you will get a good history taking. So because 90% of diagnosis is made with a good history taking, so when you have a good history taking, that will actually tells gives you a nice idea of what is going on. Okay. So these medically unexplained symptoms, all these symptoms tend to cluster in groups. For example, like GI, they could have abdominal pain, altered defecation, like nausea, vomiting, or bloating. That's for GI problem. Cardiovascular problem, they could have something like a palpitation, chest pain, shortness of breath, all those things. Musculoskeletal, as I said, joint pain, back pain, muscle pain, loss of strength in their movement. They feel very weak and all those things. And neurologically, they could have these headaches as well as dizziness. If generally means they could be having some unexplained fatigue or tiredness. They are not having anemia, but they are having this like anemia, or they are not having any anemia or hypothyroidism, but they are having this fatigue or tiredness, loss of concentration. They are not suffering from depression, but they actually have this loss of concentration, loss of memory. They are not aging, but I mean they are not aged people, that they have this loss of memory. So all these are actually medically unexplained symptoms. You exclude the possible diagnosis first, then you come to this uh, diagnosis of MUS. Okay. So, who gets this? So, MUS are more common in people like women, okay, women, survivors of childhood adversity, or childhood adversity or abuse, adversity as in like hardship in their life, and that of close relative. Okay, probably psychologically it can actually induce some type of illness in them, and people with long-term conditions such as anxiety and depression, because they are more sensitive to, sensitized to pain, and refugees, as well as people with low health literacy. But then remember that this is correlation, not causation, and this can occur in anyone. Okay. Okay, so now I'm going to talk about a few disorders. Okay, the first one that I'm going to talk about is conventional disorder. Okay, conventional disorder is basically like is a psychiatric condition that results in a neurological symptom without any underlying neurological cause, like as in like a patient might experience seizures, weakness, non-responsiveness, numbness, or even vision loss. And this, remember that these symptoms are not intentional. That is, the patient is not faking or intentionally creating their complaints. Yet, upon further investigation, with no biological explanation for the symptoms can be found. Okay, that is conversion disorder. Now, we'll go on to factitious disorder. What is being meant by factitious disorder? Okay, Factitious disorder and malingering is closely related, but people tend to confuse between these two. Okay, factitious disorder, by definition, is like individual fabricates or exaggerates physical or psychological symptoms because they enjoy being in the sick role. Okay, and symptoms are sometimes fake but may also be induced. For example, like a person might take something like induced to cause them to vomit, and it can happen as a single episode, but generally patients will have recurrent hospitalization because they this type of patients, they are very knowledgeable about symptoms that they want to like show off as real. And individuals, why they are doing this, they are generally motivated by sympathy from others, and they are also not faking it the symptoms for money, time off work or medication. If they are actually faking the symptoms for money, time off work or medication, then this is a different condition known as malingering. And they can also be doing this subconsciously, like they might not even realize that they are actually fabricating it. Okay, so that is the difference between malingering as well as a factitious disorder. So when we are actually dealing with this type of patient, there are certain mistakes or unfavorable situations that might happen in clinical practice. Not might happen, but it usually happens because doctors, they deal with a lot of patients in one day, and suddenly one patient comes with a like not a proper diagnosis that might actually like tend to piss them off or irritate them something. So they tend to not check on them properly. Okay, so what usually happens in the clinical practice is like probably the doctor doesn't give an explanation. The doctor might say like that means like the doctor might say like there's nothing to worry about, or secondly the patient doesn't believe the explanation that the doctor have been given, or third, the patient does believe the explanation but then anxieties problem, they keep coming back, and some patients are given a reasonable explanation for the symptoms and they feel temporarily reassured, but then after the anxiety attack kicks in, the worries return. Okay, so when GP deal with this type of patient, the things that could be typically done to these patients by this GP is history and examination, investigations such as blood tests, or any acumental investigation, for example ultrasound or anything, and probably might refer them for like a secondary care or tertiary care. And while waiting for their period of treatment from the secondary or tertiary care, we will like treat them symptomatically. Okay, and if they comes back to you, then GP might actually order another test, prescribe another medication, or tell them that okay, we haven't found anything wrong with you. Okay, or they might even say like there's nothing else we can do to help. So all these things are not going to help the patient. Okay, because they are not going to understand what is going on with them. So the proper way of dealing with this patient is we must take a full history, even if you have seen them. Explore the symptoms in detail, which helps to ensure nothing is missed and also that nothing new is developing. And explore also their cognitive aspects like ideas, concerns, and as well as expectation. Ask about the social consequences of the problem and ask also about the behavioral consequences of the problem. After you have told everything, try summarizing it as a technique. After everything is done, then you explain about what is medically unexplained symptoms. Tell them that the symptoms are common but not always attributable to a specific illness. And we must also train the patient to switch the focus from what's wrong to thinking about managing the symptoms. And talk to them about the favorable longer term outlook, and that it doesn't always mean that they will always have them. Okay, because an empathic relationship that is patient centered is prognostically favorable for MUS always. Okay, and if all these methods are not working, then you can like offer another opinion from a colleague if they haven't had this. But remember that repeated consultation often reinforce underlying beliefs about causation in the disease of the patient, that the patient is assuming. Okay, so that's all for this video. Thank you.